We're here to talk about
Burnout.
Burnout.
burnout. It's a word we hear constantly in medicine, but it doesn't look the same in every specialty. In this series, we bring together physicians from across medicine to talk about what burnout really looks like in their field. This is Burnout by Specialty. Welcome, everyone, to Burnout, a Specialty series. Today's episode is on emergency medicine, and thank you to Doctors on Social Media for hosting this series. I am Mary Ramon. I'm a licensed counselor and coach for doctors, and today I would like to welcome and thank Dr. Cecilia Cruz, Dr. Stephen Sabo, and Dr. Brian Young for joining us today. So let's start off with brief introductions. Dr. Cruz.
Sure. Hi, my name is Cecilia Cruz. As you know, I'm an ER doc by training, practiced emergency medicine for about 23 years. I'm not currently practicing emergency medicine at this time, but I practiced in both the academic and community setting and held some administrative roles while I was working as an emergency medicine physician as well.
Thank you. Dr. Sabo.
Hi, my name is Dr. Steve Sabo, emergency doctor. I practiced for 28 years in New York and New Jersey. And 2 years ago, I transitioned to prevention and longevity. And now I help health-minded professionals create a greater impact.
Thank you, Dr. Sabo. Welcome, Dr. Young.
Hello, my name is Brian Young. I practiced emergency medicine for 13 years. My training was in internal medicine and surgery, but I found emergency medicine more attractive, at least initially. And so I no longer practice emergency medicine, but I was in Ohio working in community emergency rooms, mostly. A little bit of academic, but not much.
Well, thank you all. Wonderful backgrounds. I recently read that once again, this past year, emergency medicine is the specialty with the highest rate of burnout. And so you all are survivors. I understand, Dr. Sabo, you have 28 years in emergency medicine?
Yes, it's hard to believe, Mary, but 28 years it was.
That's incredible. And Dr. Cruz, I'm just curious from your perspective, what does burnout look like in emergency medicine?
How's it different?
Anger. Okay, tell me more. Yeah.
Resentment, disconnect. I'm hoping Dr. Sabo and Dr. Young will agree with me, but most ER docs were pretty tough. And our motto, one of the mottos in my residency program way back when is you can do anything for 28 days. Our rotations were all 28 days long. I did my residency at University of Illinois in Chicago. And, and so it's really just put your head down and work. And we were okay with that. And so I think in emergency medicine, few doctors will say or even know that they were burned out. They will, it will come out in resentment, in anger, in feeling victimized, abused. And as this increases again, it comes out in those other ways.
Thank you. Dr. Young, I'm curious from your perspective, what is it about emergency medicine in particular compared to other specialties that makes burnout different?
Well, it took me a long time to kind of arrive at some of these conclusions, but the biggest thing for me is this state of hypervigilance. You're asked to kind of be prepared for some potentially dire things across the spectrum in the settings I practice, from nearly newborns on up to people that are 90 to 100 years old. And they say, kind of called emergency medicine, the first 30 minutes, what you do initially can be fairly critical in terms of the outcomes. And then when you layer that on the fact that emergency rooms are expected to basically take all comers, and a lot of that is non-emergent problems that are indicative of the social decay of our society, and the ER is like one of the only places people can show up and maybe try to get things addressed. It was an insolvable conundrum for me. I could not hold the line, so to speak, and maintain that vigilance and that focus and that mindset to be ready and prepared for everything while basically running a, kind of a 24-hour primary care, urgent care clinic, at the same time. I don't know if that's how other people feel, but I know it really stressed me in ways that I was just never able to feel harmony with.
Thank you for sharing. I can't even imagine. Dr. Sabo, our survivor of emergency medicine for 28 years, what would you say is the part of the job that you found to be the most draining when you were practicing?
I'm thinking of, the episodes of, I'm sure you've all seen the show, The Pit, and really quite accurate. I remember the show ER and date myself, but, some of the shows before that. And it's really very accurate about how a lot of the administrators really will get in the way of what you're trying to do in the ER. And a lot of times it's like nonsense. And you're there trying to save lives and doing your job, and they want to know about you following some irrelevant protocol or something else that's going on. And they're not looking for the same thing in the ER that you are. You're looking for the best for the patient. And I always found that to be really difficult. But like, I guess it was Brian that was talking about, basically describing the ups and downs. And I think that it's us as ER doctors, recognizing that a cardiac arrest or a trauma arrest can come into the ER at any moment. You may be doing a laceration, and plenty of times you're in the middle of something and you have to multitask. You cover up the patient's hand wound or whatever, and you go do the cardiac arrest. One of my hardest days was being a single coverage and having a pediatric cardiac arrest and an adult cardiac arrest simultaneously. So I think I spent most of the time in the pediatric arrest and had the charge nurse running the cardiac arrest, but I would go back and forth. Did I answer your question? I don't know. I think I'm just yeah.
You made it quite vivid. Thank you. Can't imagine. Dr. Cruz, along those lines, because Dr. Sabo was talking about how administrators will come in with just these random, irrelevant things. I'm wondering, what do people outside of emergency medicine not see?
Ooh, that's a good question. I feel like a lot of people don't see that we're human. We have families and loved ones and lives that we also have to deal with. The expectations, I think, placed on emergency medicine physicians is that anyone can come into the ER, and that it is our job not only to treat them, which, of course, yes, that is our job, but also to make it this almost comfortable and luxurious experience. I think ERs, again, I think Brian was maybe leaning towards this, that because there is, right, they're emergency rooms, but oftentimes the patients that we're not seeing are emergent. They're coming in and they're expecting to be seen in order as they came in, or seen, I don't understand why I'm waiting for so long. And then they don't understand, again, that our job is to take care of emergencies, to take care of the sickest people first. And that there's, again, that we're human, and that there's only so much that we can actually do with the tools that we were given in the system that we practice in. I agree with Dr. Sabo that the pitch is very realistic, but I think like some other programs have made people believe that, they can come to the ER and that an ER physician is going to be the doctor that's going to do surgery for them, or that the ER doctor is going to solve and they don't, something the misunderstanding that we're there to treat the emergencies, and then everything else we kind of triage, right? Like, where do people go? What's the next step? And, they don't understand why they can't have their mole removed in the ER the moment that they want that done.
Thank you. I can only imagine the types of serious and benign things that people present with and the expectations that are mismatched. So you described that well. Dr. Young, I'm going to pick your brain again. When you were practicing, I imagine there were a lot of system pressures, and what types of system pressures tend to hit you or your colleagues hardest in emergency medicine?
Well, I think the notion of throughput, that you're going to Dr. Cruz's point, kind of be establishing rapport at light speed, making decisions at light speed, getting everybody's issues addressed in a timely manner per their satisfaction. I don't know if it was the case in Dr. Sabo or Dr. Cruz's locations, but I'm in Southwest Virginia, and there's billboards for Carillion that say ER wait times, but we don't see billboards, which is a throughput thing. Don't see billboards for the number of days you have to wait to be seen by an orthopedic doctor. There's no billboard for that.
Seeing double? That's our cue for a break. We'll be right back.
Join an eye-opening speed virtual networking session each month, meeting new peers, making new connections, all exclusively from SomiDocs.
Don't leave without reading the article, Lifestyle Medicine for the Physician, Not the Patient. In it, Dr. Stacy Funt, speaker at the second annual SomiDocs Lifestyle Medicine Conference, says, when identity shifts, healthy behaviors become congruent rather than forced. Check out her words, her work, and the rest of the topics you can learn through virtual access of this event. Now back to the show.
I'm in Southwest Virginia, and there's billboards for Carillion that say ER wait times, but we don't see billboards, which is a throughput thing. Don't see billboards for the number of days you have to wait to be seen by an orthopedic doctor. There's no billboard for that. Among other things, and systemic issues in primary care, but ours get posted on billboards. It sets expectations. So that type of a system expectation for throughput, and that's braced against systems that aren't necessarily set up for throughput. The issue of ER overcrowding now is present almost everywhere, and it's just, I guess it falls back to burnout. It's that sense of agency and the fact that you have control, a span of control over the things you're being asked to do. But issuing forward from residency programs where the emergency room is kind of the bane of the existence of all residents, because we're giving you kind of random, sometimes caseloads and sometimes a lot, depending on what comes in, that, feeling about the emergency room on the part of, say, family practice doctors or internal medicine doctors persist. So when you go to try to call to get, kind of set up dispositions, get people admitted or whatever, there's sometimes pushback there, the system. So it feels like over time as an ER doctor, you're kind of caught in this crush in the middle. The noted metrics are that somewhere between 33 to 40% of all hospital admissions come through the emergency room. The notion being that it's some sort of revenue generating center, which it's not set up to be. I could go on, but I'll stop there. There's three things that kind of are trapping, particularly in single coverage ERs, which is where I worked. You just feel like the man in the hot seat without the ability to kind of route, direct, move fast, because, to your point, of some of these system-related issues.
Thank you, Dr. Young. I hear a lot of pressures from different directions. I've seen those billboards with wait times, and I've also heard ER doctors tell me about patients on stretchers in the hallways and treating people in the waiting room, and it just sounds very challenging. Back to you, Dr. Cruz. There's a lot of talk these days about sustainability in healthcare, and I wanted your thoughts about what are the things that feel most unsustainable about emergency medicine?
Pretty much everything that's already been mentioned. Every day, ER physicians are asked to do more with less. And it's really been in a really fairly short period where it's really just come to a head. And so back in the day, so to speak, even in the early 2000s, you could go to most ERs, and obviously it would vary from day to day and exactly where you were working. But in the evenings, for example, or night shifts, there would be nights, not every night, but some nights that were less busy that you could almost catch up and like take a breather, or some days that doesn't happen anymore anywhere, at least anywhere. I mean, maybe in really rural areas, but nowhere anywhere, near a metropolitan city. And there's what you just said, patients in the hallways all the time. And one thing that I wanted to point out that you briefly mentioned is the patients in the waiting room. I think people don't want, another thing, kind of going back to the question you asked before, people in the world, or I think even other physicians outside of emergency medicine, don't realize that when a patient enters an emergency room, that physician that is working in the ER, you may have never seen that patient, spoken to that patient, known you see the list, but you are now responsible for that patient. If something happens to that patient in your waiting room, it's on you. And most ERs, there are hours and hours of waits with 40, 50 people in the ER, in that waiting room. And yes, of course, they're being triaged, and yes, they're trying to but it is impossible to always do that properly. And so none of this is sustainable. Again, ER physicians are asked to do more with less every day. We're at the brink. And if something continues to happen with what's going on with people's insurance, and where all the people in the country that don't have access to insurance, where are they going to go? The ER. So it's only, again, unless something happens, likely to get worse before it gets better.
Thank you. I do hear physicians telling me not to present to the ER unless I'm actively dying. So I heed that advice. Thank you, Dr. Cruz. Dr. Sabo, you lasted a long time, as we said, in emergency medicine. And I'm really curious, what do you think it is that keeps people practicing despite all this?
That's a really good question. And I think I've told you that, when I left the ER I was working at, most of the doctors were not happy and were thinking of leaving, and including one that had only worked, I think, 8 years or something like that. He was looking to do something else. I think they have a saying, when you go to work, you do work. When you go home, you don't do work. And I think that was something that I did over the years. I wouldn't bring charts home to do. I would finish them at the hospital. So I didn't. And I tried to be present for my family when I was out of the hospital. The other thing I started doing, and I don't know if it's been my last 5 years or so, is I started meditating. I would get up, if I had a 7 a.m. shift, maybe I'd get up at 5 a.m. and I would do some things that meditations that would help me relax. And so I always came in with a very positive attitude, and which is probably why a lot of the nurses and other doctors enjoyed working with me, because I always try to maintain an even keel as opposed to kind of going up and down. I mean, look, as the other doctors have mentioned, we all can get stressed out, certainly life or death. It's not all life and death, as everybody has said. But when your heart starts pumping when they say cardiac arrest coming in or trauma arrest coming in.
Thank you. You have amazing survival skills, and it shouldn't be so hard for our best and brightest. I think people who've made it through medical school are the ones who can go without sleep and can last a long time. And if it's burning out our best and brightest, we have a problem, right? There was a little bit talk about earlier, Dr. Sabo mentioned, leadership coming in with kind of clueless questions and things like that. And Dr. Young, I'm curious to get your thoughts about, what do you wish leadership understood?
Maybe primarily the need for perhaps a nuanced understanding, a deeper understanding, and the need for support. And that if your emergency room doctor or your emergency room department or staff are saying things about patients stacking up the hallways and throughput or any of the issues that have been mentioned, that they need to kind of lean in a little bit, like maybe they might with other service lines when they're trying to streamline, things for efficiency, and really kind of have some talks, some come to Jesus moments about what they need to do to kind of relieve some of the pressure in that situation. The emergency room is not a place to kind of play around, so to speak. It's kind of really seriously the front end a lot of times of the hospital and the health system, and I think by virtue of that holds a more kind of prime position in terms of these notions of being responsible for the health of a community and the like. You want to make sure that front edge battle line is just like we do with our American troops. We try to get them the best weapons, the best gear, so that they're set up for success. And I don't feel like that happened in the settings I was practicing in. The emergency room is kind of like this backdoor channel coming up through the basement, kind of a feel to it all. And it's just not the way to manage things, in my opinion.
Thank you. Some of the physicians I've coached do have a military background, and it seems like there's a lot medicine can learn from the military. Dr. Cruz, I know that many, many things need to change, but if just one thing changed, what do you think would reduce burnout the most?
Throughput. So kind of going to what Brian was saying, if administrators paid attention to how we can move the patients from the ER, patients that need to be admitted from the ER and get them out of the ER as quickly as possible. It's very, very demoralizing and very, very difficult to give patients the care that they need when they are sitting in a hallway. You can't do a proper exam. No one, is paying the attention to them that they need to get. It's difficult for the doctors. It's difficult for the nurses. If there was one thing that could be changed, I think that would make a huge difference.
Thank you. I think that's helpful for administrators and physicians to hear.
Yeah, I totally agree with her. And the other thing I noticed over the 28 years is some of the same types of problems leading to the overcrowding that she's talking about that existed when I first started my career was still going on today. Because if you think about it, a nurse is upstairs on a floor. What's the incentive for them to call the bed board office and say, hey, my patient just went home and the bed's empty, it just needs to be cleaned, when she has 2 hours left in the shift and doesn't want to take another patient from the ER? And obviously the objective of the people in the ER is to get the patient back, upstairs.
We'll be right back.
Here's a snippet from our series, Even Doctors Need Life Lesson.
Now, I have 4 tricks. They're not my tricks, but this is the recipe that I think every story requires. So I'm going to walk you through those, and hopefully that's what you can take away with you as you think about how you want to tell stories. The first thing I want to say is you've got to be authentic. Now, I know that word is totally played out, and who knows what that even means. But what I mean is that we all have our own storyteller DNA. It is Mary Abel-Fazley that can talk about shitting in the church bushes. It is not everyone else. And you shouldn't try to take on somebody else's personality or style or voice or expression to try to be interesting or impactful. You have to dig within and be yourself.
This series is free to access and features lectures on various life skills from 14 experts. There is also a companion physician panel discussion for each lecture. Find it in our series section. It's like Netflix before healthcare.
Finally, back to our show.
A nurse is upstairs on a floor. What's the incentive for them to call the bed board office and say, hey, my patient just went home and the bed's empty, it just needs to be cleaned, when she has 2 hours left in the shift and doesn't want to take another patient from the ER? And obviously the objective of the people in the ER is to get the patient back, upstairs. So unless you have, I learned this especially on a night shift, unless you have a good nursing administrator that walks around the floors and you give a disincentive to the nurses to do that, like if they hide beds, then there'll be some type of a reprimand. Then you sit with, like Dr. Cruz said, you sit with an ER full of patients all night, putting stress on everybody, including the patients. When these patients, you come on at 7 a.m. and suddenly by 8 a.m., boom, the whole place decompresses.
Such a great point, Dr. Sabo. Thank you. Thank you all. I have one final question for each of you to think about and share, and then we'll wrap up. And I don't expect you to have all the answers. I don't expect the people on the front lines to be the ones to have to fix it, but you do have insight. So my question for each of you, one at a time, is how can we make emergency medicine more sustainable? Dr. Young, what are your thoughts?
I think kind of similar to the discussion so far, just this notion that what's not sustainable seem to be more system issues or systemic issues. The doctors here on this panel, as well as me, and I'm sure almost everyone that goes into emergency medicine starts with an indomitable idealism, about what it's going to be like and their ability to help people in some very critical situations. And then you kind of crash up against that beachhead on the rocks of all of this other stuff we've been talking about. And it's just punishing over time, and it never gets fixed. Dr. Sabo said he saw the same problems existing, over a 28-year arc. Nothing's getting addressed. The system is not conforming itself for success and lining things up the way they need to be. And COVID and the pandemic just, served as a forcing function, some people call it, or a super stressor to bring out all of the weaknesses of that system. I think they should listen to the people providing care and take some recommendations at kind of prima facie value, and if that means they got to spend more money and do some things or staff more or have flex beds, there's solutions out there, but they need to pay attention and to do it.
Thank you, Dr. Young. Dr. Cruz, if you could summarize in about 30 seconds, I realize it's hard, what would make emergency medicine more sustainable?
Connection. I think that right now there's a lot of disconnections between the ER and a lot of the other specialties. Again, as our systems get bigger, we're just voices behind a phone. This is all adds to the pressure. If there were ways for emergency medicine physicians to actually get to know, and vice versa, their internal medicine colleagues that they're admitting to, all the other specialties that they're calling at 2:00 in the morning, so that there's a face behind the name, there's human connection, and you're all working together for the good of the patient, that would be huge, in addition to everything that's already been said, of course.
Thank you. And last but not least, Dr. Sabo, in about 30 seconds, what would make emergency medicine more sustainable?
One of my colleagues had an expression with regards to the upstairs administration, the hospital called it institutional apathy. Anytime I made a comment on something about the system, and for 28 years I did that. I was an administrator for only a couple years, but I think that would be made better if not only we continued as physicians giving our opinions to the upper echelon people, but they actually took some of our suggestions and look for the good of the patient, since that's what it's about.
Dr. Cruz, Dr. Sabo, Dr. Young, thank you so much for taking the time out of your busy schedules and for sharing the insights and for all the work you've done on the front line. Thank you so much for Doctors on Social Media for hosting this event. And this will conclude today's episode on Burnout by Specialty featuring emergency medicine. Thank you all. Burnout may be one word, but as we've heard, it's not one experience. This is Burnout by Specialty.